I come from Rome, from Tor Vergata University. These are the facilities of my, no, this is not facility of my university, obviously, but all the others, yes. I'll speak about the role of intra-articular management in the femoroacetabular impingement. We know femoroacetabular impingement is an osteoarticular pathology secondary to abnormal acetabulum and proximal femoral portion morphology. We know that this is a problem because it causes an early hip osteoarthritis, especially in young and active subjects. According to the classification, we distinguish a pincer impingement by a cam impingement, and a third form is the mixed form. The pincer impingement regards the cartilage and acetabular lip degeneration. The cam impingement regards the aspherical portion at the level of the femoral head-neck junctions. So, some words, I am PRM, so I'll speak about I'll use some words about the treatment. We have two ways, a conservative and a surgery treatment. I'll speak about conservative. We design a re-educational project for our patient with FA, and this re-educational project is composed by re-educational programs, that means motor re-educational programs, a physical therapy re-educational programs, and the drug re-educational programs. Faster the beginning of the treatment, better is the results. So the motor re-educational program is based on the iliopsoas and gluteus medius muscles that are leaders in the hip biomechanics. So we can treat the hip manual, we can use hip manual decoaptation, the kinematic chain stretching, and the muscle strengthening. According to the physical therapy that we can use in the femoroacetabular impingement, we distinguish and we use in my clinic electromagnetic fields and capacitive resistive diathermy. The electromagnetic fields are, we use in general 340 Gauss for 30 minutes, is a European field, and 3 times a week. This has an antiphlogistic and anti-edema and analgesic effect. About the capacitive resistive diathermy, we can use to increase the microcirculation, to have a vasodilatation and increase of temperature. The sessions are around 40 minutes each. 3 to 10 sessions per cycle is important to stop at the third session if there is no therapeutic results. And then we have a third re-educational program, that is the drug. Drug re-educational program is composed by oral topic therapy, by the periarticular injection therapy, by the intradermic injection therapy, that means mesotherapy, for example, by the intramuscular injection, by the endovenous, if it needs, by intraosseous therapy, and obviously by the intraarticular injection therapy. According to the drug, we can use paracetamol, maximum 3 grams per day. Then we can use NSAID in acute, if analgesic does not improve clinical symptoms, and then intra-articular injections by corticosteroids, hyaluronic acid, PRP, cycles repeated 2 to 4 times a year, at least 3 months apart between one cycle and the other. We know that the intra-articular injection, the hip injection, it must be echo-guided or in fluoroscopy. And it assures that we have precise target and a low technical risk. This is the literature about the scientific literature about the the injection in intraarticular injection in FA. We'll see 5 papers that are strong, up to date, and these papers are 2 original articles and 3 reviews. This article that is written in 2013 is femoroacetabular impingement, is hyaluronic acid effective, and this group, this paper is the only one, the only article cited by all the reviews, is an open prospective trial, and level of evidence is 4th. This study use 2 ml intraarticular ultrasound guided injection of hyaluronic acid at baseline and after 40 days, and then this treatment can be repeated after 6 months. All the studies about 23 hips in echo-guided. And in the follow-up, VAS score decreased significantly after 6 and 12 months, and disability was also reduced. I want to highlight that it's important not only to speak about pain, but about the functional restoration of the patient. The consumption of anti-inflammatory drugs was reduced from 14 to 4 subjects in a statistical way. So we ameliorate the function, we ameliorate the pain, reduce the pain, and we use less anti-inflammatory drugs. Hyaluronic acid is effective because of the mechanical effect, the viscosupplementation, but not only viscosupplementation, but for the biosupplementation too, and the anti-inflammatory and nociceptive effects that many colleagues spoke before me. The problem, this is not a randomized control study. A placebo effect, so, cannot be ruled out. And the conclusion of this paper is that in patients with mild FA, not yet candidates to surgery, hyaluronic acid injections may provide good early results, improving hip function and reducing the functional impairment in daily living activities. This second paper that was published by the Lee families from Korea, and is a very elegant study because they compared the use of steroids with the use of hyaluronic acid in femoroacetabular impingement. It was written in 2016, so all these papers are really up to date. So they study the possibility to treat separately with hyaluronic acid and steroids. and they treat 30 patients. And this prospective, double-blind, randomized, crossover study was aimed to assess and compare the clinical effectiveness of intra-articular injection using steroid and or hyaluronic acid. So, the responders of one treatment were followed up at 12 weeks, without additional injections. The non-responders to one of these treatment were crossed to the other treatment, and at 2 weeks using the alternative drugs. They used the fluoroscopic intra-articular injection. This is the scheme. This is a crossing over, you see. They treated 16 patients with steroids, 16 patients with steroids, and 14 patients with hyaluronic acid. This is the column of response and non-response, and they studied the crossing over response to the treatment. The patient satisfaction in general was very high. So pain intensity might be more influenced by steroid treatment rather than hyaluronic acid, but hip function may show more delayed improvement than pain intensity, and hyaluronic acid may be more effective for hip function than steroids. Limitation is the small number of patients. Obviously, this is the real limitation, the real limitation of this study, in my opinion. So the conclusion is that intra-articular hip injection with steroids or hyaluronic acid may be effective as a conservative treatment in patients with FA, but steroid can be used to obtain faster effect on pain, and hyaluronic acid to have more delayed effect. This is a review, another review about the Can group in Ontario, in Canada, about the utility of intra-articular hip injection for femoral acetabular impingement, a systematic review. And it shows us that is a well-tolerated therapy for FI and may provide significant pain relief. And many of these patients didn't underwent surgery after 12 months. About PRP, they show that there is no result about this study in the treatment with their PRP in the femoral acetabular impingement. This other review is around 2015 by an Indian group, and the conclusion is that in this population, injection should be limited to a diagnostic treatment. We published, our group published another review in 2016, and this other review conclude that we can only speculate about clinical improvement in terms of pain relief. So this is the literature. In my clinic, we use daily this treatment for FA, together with a team that is formed by orthopedists and sports medicine and PRM. Which is the procedures that we use in Tor Vergata University to treat this kind of patient. This is our experience. On my opinion, is better to use the echographic guided rather than probably fluoroscopic. It's easier to use. Another point is that it's better using hyaluronic acid rather than steroids if it needs. And steroids if it needs. Better more than 2 ml of hyaluronic acid in each injection. Better only 1 injection for section. And mobilization soon after the injection. Obviously, faster the beginning and better the results. Thank you so much.